Where is the source of this? So this is from the AUA guidelines that are published in 2018. So some of this material may be slightly out of date, but really not much. And I'll try to give some practical applications as well as we go through. So evaluation and diagnosis. I'm listing all these, but I'm going to go through them all in specifically, so don't worry about all this. But you can see them listed here, that you want to take medical, sexual, and psychosocial history, physical examination, selective laboratory testing, validated questionnaires, counseling, and this is something that Dr. Kara talked about yesterday, but counseling is something that's fairly new to these guidelines and is incredibly important, and then specialized testing in some men, not all. So for the medical, sexual, and psychosocial history, first question is, who should raise this issue? And we as urologists, we're really specialists in talking about sensitive issues and making people feel comfortable immediately. But really, you as the physician need to raise these things. Now, if the patient is coming in specifically for this stuff, of course, they're probably going to raise it. But sometimes they're not, and it really should be you who asks these questions in just a really straightforward way. Risk factors. So we know about a lot of the risk factors. A lot of these are cardiovascular risk factors. But what about the psychologic factors? A lot of men may have anxiety, depression, marital issues, which can be a primary or a secondary cause of erectile dysfunction, and men may not appreciate that these psychologic issues have an effect on their physiologic function. Now, for the sexual history, many men don't really know how the specifics of erectile dysfunction, and you have to get out of them what exactly is the problem. So you want to know how long they've had it and the severity and how much it bothers them and whether this actually is an erection problem, or maybe this is something that has to do with their libido, or maybe they have Peyronie's disease. Now, you also want to ask about the partner and preferably really involve the partner. Now, from a practical aspect, I think this latter point is incredibly important. There's obviously a big opportunity for education, especially as regards to the counseling, but the partner is even emphasized in the guidelines. So this is just a quote from the guidelines. Because of the complexity of sexuality and the impact of sexual relationship on a man's life, the panel strongly advocates that a man's partner be invited to participate. Now, not everyone has a partner, of course, but even if a man comes in alone, if they have a partner, we encourage them to come back for another visit with their partner, and we find that very helpful. Okay, so physical examination, what are you looking for? Obesity. Now, typically we've used BMI. BMI may not be really the right thing to use for looking at obesity. So maybe central adiposity, that might be something worth paying a little more attention to. Signs of testosterone deficiency, of course. Penile length, penile abnormality, so a penile exam. Scrotal examination. And I put DRE with a question mark. That's in the guidelines, but the guidelines do point out that the DRE is not there for erectile dysfunction per se, but LUTS and BPH, these are common things. So you might do a DRE if it seems appropriate. Now, I think the exam is really important, and it seems surprising to me that someone could come in for erectile dysfunction and not get a penile exam, but it happens. And what are you looking for in the exam? Well, you're looking for Peyronie's disease, and you're looking for fibrosis, you're looking for elasticity, you're looking for any cutaneous lesions. You also want to really look at the penile length. And men have a very distorted view of what is a normal length, and particularly if you're considering doing something surgical like an implant, you want to know this ahead of time, and I'll come back to that later. Selective laboratory testing. So the first one is testosterone. We know that low testosterone is common, and while just treating testosterone alone in a man with erectile dysfunction is probably not going to be sufficient to fix them, we do know that every intervention short of a prosthesis works better in the face of eugonadism. And so if a man has a low testosterone, that should be treated. Now, what is low testosterone? So typically these are 2 morning tests, and there is a lot of diurnal variation. It can be very high. So you want to do these at 1 in the morning, and then you want to confirm that with a second one. Hemoglobin A1C. Some men are diagnosed with diabetes because they come in for erectile dysfunction. So this is an important test. I find this to be the most helpful test of all of the things listed here. Serum lipids, they may have already had these done, of course, with their primary or cardiologist, but if they haven't, it's worth looking into. Maybe thyroid function, maybe PSA. Again, PSA not directly for the erectile dysfunction, but it's just part of their general men's health. Validated questionnaires. There are a few of them, and they're listed here at the bottom. And you can use whatever is yours of choice. And these are important for initial assessment, but they're also very helpful to see whether the intervention that you're using is actually helpful. And it may help guide your future management. If someone has an extremely low score, they may not do as well just taking, for example, a PDE5 inhibitor. Counseling. Again, this is something that's relatively new to these guidelines, and I think cannot be overemphasized. This is an incredible opportunity to not only improve the health of these men in general, but it also is an opportunity to make them kind of an active participant in their care, and that's what you want. You don't want someone to come in and say, well, you just need to give me an erection, but I'm not going to really do anything about it, because this erectile dysfunction can be a tremendous motivator. I'm sure we all have patients where you say, well, smoking's bad for you, causes bladder cancer, lung cancer, and they blah, 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 and say, oh, it's going to make your penis not work. Suddenly they're very interested, and they're very enthusiastic to do something about this. We know that patients with cardiovascular disease are more likely to have ED, and patients with ED are more likely to develop cardiovascular disease. So in the prostate cancer prevention trial, having ED was as robust an indicator as being a cigarette smoker or other major risk factors for cardiovascular disease. Now, what about sexual activity as a risk for a cardiac event? The Princeton 3 guidelines can help guide us along there, but patients with low or moderate, they're probably okay for sexual activity. Sexual activity is probably not as a strain at the heart as one might think. Specialized testing. This is really not for everyone. In fact, it should be a small minority of your patients who should require specialized testing. This is just a list here of some who might be good candidates for this. A young man who comes in, particularly if they've had lifelong ED, very strong history of cardiac disease in the family. Pelvic trauma, they've had other treatments that have failed. You think that maybe they have a very primary psychogenic ED. Associated Peyronie's disease, so you can get a sense of how bad that is. So what are these tests? Nocturnal penile tumescence. I showed a picture of this yesterday, or the other day, but this is not that helpful, unfortunately. So this is an idea that if you have nocturnal erections, then at least you have the plumbing that allows you to have erotic erections. But we know these are different kinds of erections, and they don't correlate well. So you can have nocturnal erections and still not be able to have erotic-based erections. So this is one that's really not done so much anymore. In-office erections, this is very helpful. So you want to assess their response to an injection of whatever sort, a Prostadil or a mixture, and this is also maybe a great therapy for them. Penile duplex ultrasound may be a little less helpful, a little more specialized test, but in certain situations, very, very helpful. Biothesiometry, while you can do it and you can get information from it, whether you're looking at vibration or sharp or response to cold, etc., it doesn't generally change your management. Cavernosography, this was done very commonly when I was a fellow. Unfortunately, it just is not very helpful because venous surgery is not very helpful. So I don't use it anymore in my practice, and I don't think it is used very common anymore, and that's with good reason. Selective internal pudendal angiography, this is going to be used for very select patients, and I'll come back to that later, but it's just for a very specific kind. Treatment. You want to consider a mental health professional. What we joke with our patients is, do you know who needs a therapist? Everyone needs a therapist. Even if the patient does not have a primary psychogenic ED, it causes great bother, and there's a lot of psychological stress that is a result from having this, just like it is from having Peyronie's disease or other kind of sexual-related problems. And so incorporating a therapist, they could be a sexual therapist or maybe a general therapist, this is important. And for lots of social and financial reasons, this is a barrier, but it still really needs to be encouraged. Counseling regarding comorbidities, I already went over that, but this cannot be overemphasized. There are a lot of behavioral issues and lifestyle issues that can be improved on for essentially every man. Now, In the past, this was considered sort of a tiered model. You'd try a PDE5 inhibitor and you'd fail that thing, and then you'd try a vacuum and you'd fail that, and you'd try this and you'd fail that. And I don't like this term failure. It makes the man on some level think that they have failed. So the new model for this is really a shared decision model. And I put this in quotes, this is also from the panel discussion, is that many men may choose to start with the least invasive option, like a pill. It is valid to start with anything. You know, in a way, our job are to be educators, and the patient's job is to become educated and then do the right thing for them in their particular situation. Every situation is a little different. The PDE5 inhibitors. Most men are familiar with these, but that doesn't mean they use them well. So we want to discuss the risks and the benefits, and we want instructions to provide maximum benefit and efficacy. So on a practical level, what is that? Well, first off, they often don't work the first couple times you use them, so they do need to try them a good half dozen times to give it a good try. The second thing is that these are amplifiers. And so we say to the guy, look, if you take these pills and watch a baseball game, unless you really love baseball, you're not going to get an erection. So they have to use them in the context that they would normally use their penis in a sort of erotic situation with foreplay and romance, etc. They titrate up. Of course, you want to use the lowest effective dose. I put a question mark after rehabilitation because while this is very commonly done after radical prostatectomy, unfortunately the data isn't really robust that this is that beneficial to use after prostatectomy. Now, there is a relationship between PDE5 inhibitors and testosterone levels. Those who have low testosterone and are not PDE5 inhibitor responders may become responders once they are rendered eugenetic. So it's another reason to check the testosterone. Other modalities, I list them here. We're going to go into these in specific detail in a second. Vacuum device. These are widely available. They're low cost. They're effective. The satisfaction I find in the literature seems a lot higher than what I see in clinical practice. The erection is very unnatural. It's sort of cold and blue, and there can be some petechiae and bruising, and the penis hinges because it's only erect at the external penis, etc. So I find that it has more of a role as an adjunct treatment. So a man who's interested, let's say, in stretching because they've had length loss from atrophy, or someone who wants to have some glands engorgement after an implant, etc. That's where I find it to be very helpful. But as a primary modality, very few patients who really choose this long term. Intraurethral suppositories, these have not changed in years and years. They tend to be a little more successful in a clinic trial than they work at home, which is disappointing. About up to 30% of patients have pain, which can be mild, can be severe in the urethra. And the cost is high. The last time I looked at this was about $26 to $40 per use, making it basically the most expensive way you could treat erectile dysfunction. So on a practical level, our use is confined to the VA. The VA, when they're available, we can use them, and they're not always available. But that's the only context in which I use these regularly. Injections. These are used commonly. These are great. There's alprostadil, and the FDA-approved formulations are just prostadil. But what most people use is some combination, so a bimix or a trimix or a quad mix. It is very important that you do in-office testing and instruction. There are lots of shot clinics where I live. There are lots of shot clinics where all of you live probably. They do a terrible job with this, and then these patients get priapism. They get scared. They will just never do this again once they've had to go to the ER. Pain can happen, and it depends a little on the agent that's used. So some agents will cause pain on injection, so that would be alprostadil, and some would cause pain with the erection itself, like Pavrin. In terms of what you would do if they had priapism, the guidelines do list that they can try these things. They can ejaculate, they can use oral pseudoephedrine, they can use ice, but the panel then goes on to say that these things really are not that useful and haven't been demonstrated to be useful. So they unfortunately are probably going to need a takedown of some sort. But luckily, on a practical level, we almost never see this. We have, I think, very good and comprehensive instruction. We have pretty close follow-up, so we don't have patients really get this at home unless they're really misbehaving. Follow-up is critical. And unfortunately, even the patients who like these initially, they have significant dropout, usually not from lack of efficacy, but because they think it's weird, a little bit of a mood killer. You know, you're feeling frisky, so you stick a needle in your penis. Not the most natural thing in the world. I mean, for some people. I don't know. Prosthetics. There are a few kinds out there. There's inflatable, there's malleables, or some variation on that. Satisfaction is excellent with these. Satisfaction is much better than any of the other modalities, but they're irreversible. A patient needs to know that if this goes in, they have committed to this. The analogy I use is if you get a knee replacement, you can't just come to your orthopedic surgeon and say, oh, it's squeaky, give me back my old one. That's not a thing. And similarly, they need to think about this that way. Infection, this is something that worries patients, and I've noticed that if you look at the literature that's given out by, for example, shockwave clinics or injection clinics, they will list infection as maybe 50% with these prosthetics. But that's just not true. Infection rates, of course, vary by what you read, but ours is less than 1%, and that's actually a relatively common number these days. Mechanical failure, it's going to happen eventually, but it may take a long time. Patients need to be counseled on that. Size changes. The number one source of dissatisfaction is a perception of size loss. Most studies actually would demonstrate that there really isn't any size loss, and we've followed our own patients longitudinally, and there really is no size loss at 3 months afterwards, and sometimes a size gain depending on their elasticity. But the only ones in which we see loss are ones who did not do their postoperative homework. From a practical point of view, realistic expectations are everything. Patients have to understand what these things are for. They are for function and to restore intimacy. They're not enlargement. They're not going to make you younger, none of those things. Never hesitate to delay or put off a patient who's not ready. You do not want to operate on someone only to find out later that you have chosen a bad candidate. Arterial reconstruction. This is something that's not done commonly. It's really confined for one kind of patient, which is a young patient who really doesn't have any other generalized vascular disease or veno-occlusive disease, and they have a focal lesion, something you can skip over. So this is the patient who benefits, if this is found in Doppler, from having selective angiography and then potentially reconstruction. Venous surgery, not recommended by the panel. From a practical level, it always works at first, and then it always doesn't work. This was done commonly, as I mentioned, when I was a fellow, and I don't do it anymore either. And if we can see a show of hands, does anyone do venous surgery currently? No, that's a big fat nothing. Okay, so that's in keeping with what they recommend. Shockwave, we heard an excellent talk on this yesterday, so I'm not going to belabor this, but the problem with shockwave, of course, is there are just many, many unknowns. We don't know how many treatments to give, how many pulses to use, what is the perfect energy source, what is the population who really benefits from this or who doesn't, and what are the outcomes. And so the panel concludes, as we saw, that this is something that probably should be done more in a study context. On a practical level, unfortunately, this is everywhere. This is on billboards all over where I live. It's probably all over where you live. The nice thing is that it's almost like free advertising for me, because the patients come in and say, oh, I did that shockwave and it didn't work, now what can I do? And then you can go on. Or they come in with questions about shockwave, and we have a pre-prepared handout, and we say, well, but there are other solutions that have been shown to work, so would you like to talk about those? And that is an opportunity. And there is going to be an opportunity for future research here. There's certainly, this is something that could be a good modality in the future. Stem cells, PRP. Stem cells, similarly, the panel concludes that this really should be done in an investigational setting. We don't know what's the right source of cells, what's the dose, what's the duration. There's just a real significant lack of data. And PRP is even worse. There's less data available. Again, unfortunately, these are heavily marketed and very expensive, a financial burden for the patients. So going forward, there are going to be technological advancements. Like, for example, for the surgical point of view, we'll eventually have electronic IPP. That's going to be very exciting. There's going to be new pharmacologic approaches, because remember that for a long time, we've basically had one pharmacologic approach that's widely available, which is the PDE5 inhibitors. But other things will come to market using different mechanisms. Regenerative therapies. This is kind of inevitable, and Dr. Kara again covered this very nicely, but this is what patients want. All these things that I've mentioned, other than the behavioral therapies, are Band-Aids. And what we'd really like to do is restore the natural function of a man. So these regenerative therapies, this is something that patients want, it's something we want, and I think the future direction is really going to be this direction. And with that, thank you very much.